Good morning, Kansas City. We are back at it with Talk About It Tuesdays. This is your girl, Tawana Clark Shepherd. And this morning's Talk About It Tuesday, we have a little bit of a unique setup. So I'm going to just make sure I clarify that for our listening audience right now. So some of you right now are watching me live on Facebook. And so we're going to have 2 times today in which you can catch this particular show. So we have right now with our live audience, with our live Facebookers, and then we will have the regular broadcast on 100.5 FM Urban Talk Radio at 11. And so just for anyone who might be a little confused, hopefully that clears it up for you. So today we are going to be talking about some common myths and misconceptions as it relates to obsessive compulsive disorder. And as always, I have a wonderful guest in the studio with me right now. For those of you who are looking at me, you'll see me trying to pull her in. Her name is Shanda, and I'm going to mess it up. So, as always, my guest gets to introduce themselves because I'll butcher her name. It's Shanda Curiel.
That works. Curiel or Curiel.
Curiel. Mm-hmm. Sounds like Curiel's what you prefer. So, Shanda Curiel is here with us, and she is going to be enlightening us and just sharing with us in a conversation about obsessive compulsive disorder. But I am going to allow her to introduce herself. Thank you so much for joining us today, Ms. Curiel. So we are going to just jump right into the topic. As you all know, we always start the show out with myths and misconceptions, common myths and misconceptions surrounding our topic. And so today's topic being obsessive compulsive disorder, I did a little bit of research, as I always do for my show, and came up with a few. And so I found it really interesting what I put together. I'm just going to kind of read it. And so basically, many people have heard of obsessive compulsive disorder, a mental illness affecting as many as 1 in 100 U.S. adults. And again, that's just the statistic for adults. So 1 in 100 U.S. adults. That's marked by obsessive thoughts and compulsive behaviors. Many people have seen this characterized in films. If you did not know, films or television. So we have the 2 that came to me is Jack Nicholson on As Good as It Gets, one of my favorite movies, by the way. And then also many of us think about Monk. Monk is a favorite in, I think it's I forget which network. It's like U.S. Network or something like that. The actor that plays that part, his name is Tony Shalhoub, if I'm pronouncing that correct, right? But how much do we really know about OCD? So, despite its prevalence, it's one of the most misunderstood mental health conditions out here. And oftentimes that's due to stereotypical portrayals on television shows like that, in the media. And then also people have ideas that simply are not factual. And that's why today we're going to make an attempt to debunk some of the common falsehoods related to OCD. And so we're going to start with the first myth and just have a conversation about it, if that's okay. So myth number 1 that I came up with anyway is that all neat freaks, right, have OCD. So one common sign of OCD is an obsession with cleanliness, such as constantly washing your hands or excessively cleaning household items, but a cleanliness complex can also be a personality trait, a mirror personality trait, right? So just with that first myth, people think that clean freaks have OCD. Mm-hmm. So what do you see with that?
I agree.
That's a great
first myth to discuss. I do think that the general public perceives OCD to be that cleanliness, that tidiness, not being cluttered. And actually the first example that comes to my mind, I've seen online Khloe Kardashian talking about her having OCD, and obviously I'm not her treating psychologist, but what it seems like from the outside is that she might have more of that personality disorder trait of just liking things organized and liking things to be tidy and looking pretty and having a lot of pride in that.
Yes, because that is one of the things that causes the misconceptions. I have noticed that it's like there was a trend some time ago. I think back to, for instance, how the word retarded became part of the common language. And I'm just going to say, some people really don't understand that it's offensive. I didn't used to understand that it was offensive. There are many mental health disorders that become a part of common language, and people then begin to use them flippantly. And I have OCD, or you're so OCD, right? So we see that, and you see that played out when it gets to a level of celebrityism. Then you really have to work hard to debunk those myths, because after all, we believe whatever our celebrities say, right? They have a lot of influence. But you're saying there is, from your observation, which is, as practitioners, that's how we make assessments, one of the ways, is to observe, and you're saying that from what you observe, there may be more of a personality trait.
Yeah, and there's a difference. I mean, there is some overlap in both conditions. There can be a theme of cleanliness, being detail-oriented, perfectionistic, maybe even morally righteous. However, they play out very differently, and with OCPD, those individuals, which is obsessive compulsive personality disorder, those individuals feel very good about their behaviors that they engage in, and that it's in line with their values of their life. And although it may be time consuming, it's a very different feeling, having pride in what you're doing and feeling good about what you're doing, versus someone with obsessive compulsive disorder, where their behaviors are not in line with the way they want to be living life. They feel like they have to do those things, but they're actually miserable. And it's more coming from sort of this rule that their brain is making up that they have to follow, which is a very different thing.
So now you've hit on something very important. You're saying there's a difference between OCPD and OCD.
Correct.
Yes. So hopefully we all caught that. There is, because people tend to use them interchangeably.
Yes, they do.
Yes. And so you're saying that there is a sense of angst and heaviness for those listening, understanding just in more common terms, there is a sense of dread almost with OCD.
Correct.
Right?
Yes.
So individuals, so if someone says that they have OCD, they're not going to be flippant about it. They're not going to be casual. They're not going to, oh, I'm just so OCD, or you're so OCD, right? Those comments probably are not going to be present with a person that has OCD, right? But if someone has OCPD, then for them, the behaviors are acceptable. They consider it a part of their value system, is what you're saying.
Correct.
Right? And they feel very good about participating in the ritualistic behaviors.
Yes.
Right?
Yes.
Okay. So, wow. See, so I've learned something today, because that's not my specialty, by the way, y'all. You know, just and that side, misconception is that all mental health specialists specialize in everything, and we do not. It's not possible. It just isn't possible. So, let's tackle myth number 2. So, OCD is all about cleanliness. Sure, a fixation is, well, we said that already, didn't we? I said that already. I think I said that. So it's not all about cleanliness. Oh, yes. I wanted to tackle just to tie up that particular myth. So other compulsions also are present, because people think it's just about, that's why I put that on there. They think it's just about cleanliness, which is probably what you think Khloe, you said whoever, one of them.
Kardashian.
Yeah, Khloe is saying, because she's clean, she's neat, right?
Well, and she organizes like her cookies in these beautiful jars, and it looks amazing.
It looks amazing, doesn't it?
It does.
I bet it does.
But yeah, it's not just about cleanliness. With obsessive compulsive disorder, I always say everything under the sun is fair game for OCD, and there is quite a wide range of concerns within that condition. So it can be something as sort of quirky as, you know, if I don't tap this a certain way, that I'm not going to be able to tolerate the discomfort, to a fear that I'm going to do something immorally wrong, to a fear that someone's going to be harmed in some way, including myself, and I may cause it on accident or on purpose, or something in the environment may cause it, another person or a natural disaster. There's just such a wide range of discomforts and fears that we see within OCD.
So there is things such as hoarding, checking and rechecking, kind of what you're saying, that you didn't make a mistake, fearing that something bad, such as a fire or accident, or repeating routines such as going in and out of a door, right?
Yes. Yeah, so some of the behavioral compulsions that you're referencing tie back to their original obsession, which is more what I explained. Sorry, you wanted compulsions. And yeah, they can range from checking to repeating behaviors to washing. There's also mental compulsions, which a lot of people don't realize. So there are someone can compulse all day long and you wouldn't even know it. And so that's why sometimes I get individuals in my office that say, I have pure O, or pure obsessions. They think they only have like the first intrusive thought, image, or urge that pops up, and that's it. They think they don't do anything in response to that. But usually if I do some digging, I can find a mental compulsion. Actually, I always find mental compulsion.
And explain that for mental compulsion. So you're saying, they think that they're having a pure obsession, which means it's in the thought, right? But you're saying that they're kind of disconnected from the fact that there are behaviors that follow those thoughts.
Correct. So technically, diagnostically, you can have obsessions or compulsions or both, but I've never seen a case where you don't have one without the other. So typically, in response to that first thing that pops into the mind, which is the obsession, they'll either engage in a compulsion that's in their mind or behavioral that people can see, or they'll engage in avoidance in their mind or avoidance that people can see. So the ones that people can see for compulsions would be like, checking things. But in their mind, the mental compulsions are self-reassurance, replaying events that just happened, prayer, counting, checklists. All of those things can be turned into mental compulsions to just kind of, they're trying to establish some kind of certainty or to bring the anxiety down. And it does work in the short term, but in the long term, any compulsions or avoidance are harmful, and it just becomes this cycle that has to be repeated.
And so you're saying that that there's an obsessive thought, right? Or an anxious thought. I'm using layman's terms, right?
Sure.
And that's followed by maybe the rechecking or the need to stop and pray, but they're realistic. We're not saying that any of those things in isolation are signs of OCD. What we're saying is when it becomes ritualistic and oftentimes misplaced, right? So you're saying that there is a difficulty sometimes where, and that I believe is where the therapeutic intervention is helpful, is that they're not aware that they are going behind those thoughts and doing that checking or prayer. They're not making the connection.
Right.
Always.
Some individuals don't make that connection until
but other people can see it.
They might see you, if it's a mental compulsion, they might see you sort of checked out and kind of you're in your head.
Okay.
But other times, you could be functioning at work all day long and no one would know.
Okay.
So
when we come back from our break, we're going to talk a little bit about one thing you just said, which is you can be at work all day and no one would notice. So we're going to talk a little bit more about some more myths and misconceptions, but then talk about, at what point then does it become harmful? So we're going to go to break. make sure you come back. Make sure you stay with us. If you are listening on our Facebook Live audience, stay with us. We're going to be back shortly. You are listening to Talk About It Tuesdays on 100.5 FM Urban Talk Radio. All right, so we are back. Welcome back to Talk About It Tuesdays. We are discussing obsessive compulsive disorder. And also, before the break, we discovered that it's also obsessive compulsive personality disorder. Not to be confused, the two are not synonymous. We have our guest with us today, Miss Shanda Curiel. She is a practicing psychologist. Am I saying that correct?
Yes.
Yes. That specializes in this area amongst others. And so she has been having a great discussion with us, enlightening us about this particular disorder. Before the break, we kind of hit on something where we were saying that some of the behaviors, that there are two manifestations, that it can be the thoughts that you have, but then also the behaviors that follow those thoughts. And so Ms. Curiel had highlighted the fact that for some individuals, they can have the thoughts that are also followed by behaviors, and can be in a workplace environment all day long and no one would even notice that they were struggling. So then the question becomes, at what point do the manifestations become problematic? What have you seen? So let's say a person has a normal functioning work life and they're struggling with this. At what point does there become a problem? Does it become problematic?
Sure. Well, I think that if it takes several hours, it's really hard to measure because it's intermittent throughout the day. And you may or may not get a break depending upon how much you're being triggered in your own mind or how much your environment is triggering you. So if it really could go on for several hours a day. And so I think diagnostically it needs to be altogether at least an hour. However, usually it's much more than that. And sometimes it's the time-consuming nature of the mental compulsions. Sometimes it's the time-consuming nature of the behavioral compulsions, how much time it's taking during the day. Maybe there's something that the person has to avoid that they don't want to avoid because it's really important in their life, and so then they'll seek help. And of course, there's also the individuals where the content of the thoughts really bother them, and so that's why they ultimately seek help.
Okay. So then oftentimes it'd be safe to assume that maybe even as we compile statistics, that there's maybe a huge chunk of the population that we're missing because the compulsions haven't gotten to a problematic state for them. They're able to function for them normally. There's no complaints from people around them. Mm-hmm. In other words, the compulsions haven't become harmful in any way.
Mm-hmm. Usually it causes them a lot of distress mentally, but it may not be, the harm may not be visible outwardly. A lot of what we see actually is that individuals will hide it or not open up about it because maybe the content they feel is scary and others would judge them. So we tend to see more of a problem with that, just people not feeling comfortable enough to open up, feeling like they're alone and they're the only one that are having the kinds of thoughts that they're having. And so that can keep them from seeking help as well. But absolutely, there's a lot of individuals who have OCD and are high functioning and try to push through, and then there are those that are more incapacitated.
Okay. So then we have another myth. Stress causes, the myth is that stress causes OCD. People think that someone with OCD should just try and relax and just stop obsessing. Mm-hmm. Right? She's smiling for you all who can't see that. Is it really that simple?
It's definitely not that simple. Otherwise, they would do it because they're so miserable. They would stop it if they could. What's happening is the brain is sort of signaling off these false alarms that either there's something to fear, there's some sort of danger, or there's going to be some level of discomfort that the person can't tolerate. And so once that thought, image, or urge pops up into their mind, what we see happening is the individual engages in one type of cognitive error, one type of thinking mistake, which is misappraising the situation. And so once they do that, they suddenly feel like, okay, I need to do something about this. I'm suddenly responsible. I need to fix it. I need to bring down my anxiety. Sometimes it's keeping people safe, and sometimes it's just correcting something that feels wrong. And so then they will respond with that compulsion or that avoidance, and it feels like that's the only way to make it better, so they have to do it. And sometimes the brain tells them, if you don't do this, then something bad's going to happen. And so that's why they can't just stop it. It would be like fight or flight going off and you not responding. That would be really difficult.
Okay. So this next one is kind of related to that one, actually. So we're talking about causal factors now. So stress is thought to cause it, and then other people say that you absolutely had to have had some sort of childhood trauma, dysfunctional home, poor self-esteem, whatever happened in the childhood. It's assumed that is the cause of OCD.
Yes, you're bringing up the best misconceptions and myths out
there.
That's so awesome. Yeah, so for sure, we definitely have a ton of individuals with OCD that have never experienced a major trauma, and then there are some that have, and some individuals have experienced a trauma that doesn't relate to their OCD at all. So I would say only a percentage have had a trauma that sort of intertwines with their OCD, and the theme carries over. But basically, I think individuals could be born with a predisposition to neurosis or anxiety. There is a genetic component, but not everyone that has a parent with OCD will have OCD. So it's not, 100%.
Mm-hmm.
And also environmental factors could play a role. Psychology doesn't tend to take a stance on nature or nurture. They usually present both in most instances. And so I sort of see it as the perfect storm, sort of occurred, and then this individual developed the full-blown disorder.
Okay, so to be clear, you're saying that in your experience, it's kind of a mixture of things that may cause someone to manifest OCD.
Right.
And so is that the same with OCPD? Do they have the same causal factors? Because you're saying, like, for instance, one they're not really stressed out about it, right?
Mm-hmm.
They're just having manifestations, but it's not causing stress.
Yeah, with the OCPD, I think the only problem comes in when it starts to impact their functioning in some way. Like, again, they feel very good about what they're doing, but somehow there's some consequence to what they're doing. I'm not specialized in OCPD, so I'm not sure about the exact causal factors there.
Okay. So then the next myth is that OCD is rare in kids. At least 1 in every 200 kids and teens has obsessive compulsive disorder. It can strike as young as 4 years old, so on and so forth. So what have you seen with children and OCD, or what have you experienced? Is it true that it's just rare in kids?
No, it's absolutely common. We see OCD develop between 8 and 12 sometimes in children. That's kind of a more common age range where someone might develop OCD if they're going to develop it in childhood. And so it's very common, and usually the fears and discomforts and concerns are exactly the same as the adults.
Okay. And so you said you've seen it start as early as 8 years old.
That's a common age range for onset, so 8 to 12. But it's been visible in children much younger than that.
And I would think that with children it would be hard. This misconception comes because it's hard to differentiate it between, I don't know, just going through stages where you're being odd, right? Because kids cycle through stages, right, pretty quickly, it seems. And so you might think of it as an odd stage. So what is something that a parent could look for that would let them know that no, this isn't an odd stage. This is a sign of possible OCD?
I would say the level of perseveration on whatever the focus is. So usually it comes from fear. And so if you think of fear as irrational or excessive, and their response to the fear, or even just how much they think about the fear, is time consuming, it's impairing functioning, the level of distress is intense, then at that point you might want to consider having it assessed. And there are other conditions where, perseverating on something is a part of it. So you want to really have a good diagnostic workup to make sure it's truly OCD.
And explain for our audience what you mean by perseverating. So they know what they're looking for.
Yeah, so perseverating, I just mean focusing on a particular topic, person, place, thing, and sort of not being able to let go of it.
Okay.
And that can happen with other conditions as well. So
exactly, and because what comes to mind for me right away is children who might be on the spectrum.
Exactly, that's what I was thinking.
Right, and so a lot of times we know as practitioners, one of my biggest burdens is watching how often children are misdiagnosed, therefore not properly treated, therefore, it has a lasting impact, right, on how they grow up and how they mature, how they develop. It has a lasting impact. And so it's really important, and it's interesting that we're talking about this today, because I'm sitting here thinking about how many times I've actually heard someone even vocalize that what they're seeing in a child could be OCD and not a spectrum disorder. Honestly, I can't think of one time. Which, I don't know what that is. That's frightening, or it's frightening right now, because I'm thinking about how often kids may have been mistakenly diagnosed and treated, right, as if they had a spectrum disorder, which comes with a whole other mixture of things when it was OCD. And so it's really important that parents and those of you who are listening, that you understand how important it is to get the correct diagnosis. I cannot emphasize that enough, because our system is set up to try to be as diagnostically accurate as possible. But it's just like with a physical ailment, right? You can go in with a stomach issue, but it could be many, many things. However, if there's not a good assortment of things that you consider and you actually rule out, then the first thing that you think of or come to that conclusion could be what the child ends up being diagnosed with. So we are at another break, and so again, if you are listening, come back. If you are watching, stay with us. We are going on break. You hopefully are listening to Talk About It Tuesdays, 100.5 FM Urban Talk Radio. And so we are back with our discussion today on obsessive compulsive disorder. We were talking before the break with my guest, Shanda Curiel, who is a psychologist that specializes, amongst other things, in obsessive compulsive disorder. We've been talking this morning a lot about the myths and misconceptions, and we've just been kind of breaking them down one at a time and having a discussion about them. And before the break, we talked about how we oftentimes misdiagnose our children, that there is a myth that it is rare in children to have OCD, when in fact oftentimes it could be OCD, but it is diagnosed as other disorders, specifically a spectrum disorder. And so we were talking about how it's important that you get the correct diagnosis for your child if they happen to be perseverating, or for more common terminology, focused in on more of a ritualistic type of behavior, or obsessing, if that's okay to say, right? Go ahead.
Oh, I was just
Jump in. Go ahead.
Yeah, I was just going to say the way the public uses the word obsessing versus the way clinicians use that word. I'm always very careful about that because people use it so flippantly, as you said.
Yes.
So I tend to use obsession as a noun clinically, just to try and differentiate. You know, an obsession is a thought, image, or urge. To differentiate it from when we really like something.
Yes.
You know,
that is so true. Thank you for clarifying that. Yes, because to really like something is not necessarily an obsession.
right?
You know, it can be a habit that forms over time, and it can be a habit that isn't always. And again, there's that difference. Sometimes can be hairline, but it is a fact. Still doesn't change the fact that it's a fact. That you can even like something to the point where it becomes a habit. You can become a collector, you know, of that thing. That still does not qualify you as being OCD. And the fact that you just have to have cars and you love cars, or like you said, pretty cookies organized in a jar, and the jars sitting on the shelf very neatly, does not necessarily. You can like your clothes in a certain order, and I've heard people just very flippantly jump to OCD because they like all their blues together and all their whites together. And so that's what this show is about. It's about, you know, raising awareness, talking about it to a point of better understanding. So let's see. Oh, I like this next one. One of my Facebook persons said something about women, educating women and making women aware. And so this next one, it said that another myth is that OCD is a woman's disease. That while it may seem like more women than men would have an anxiety disorder like OCD, but according to the International OCD Foundation, OCD affects men, women, and children of all ethnic, racial, and economic backgrounds at similar rates. What have you seen with that? That people have this assumption. I have something twirling in my brain right now about why that might be, that just hit me, but what do you say to that?
Well, I agree. I mean, it definitely doesn't discriminate, and we do see individuals from all walks of life, all socioeconomic status, and men and women. In fact, in children, boys are more likely to have OCD, at least by a little bit, and then it levels out in adulthood and it's even. So it's just as common, you know, there's no demographic factor where it discriminates.
So part of that myth debunking is that OCD, which we just discussed, tends to be completely and totally matched up with obsessing. When we misunderstand what obsessing actually means, it's easy then to see why people would jump to the fact that it's more of a woman's disease, because women are stereotyped to be more emotional. Therefore, we're more anxious all the time. Therefore, we're more likely to be women. I say we because I'm a woman. We're more likely to be emotionally attached to things, or emotionally triggered to the point where we feel like we have to engage in ritualistic behaviors, or more emotionally prone to needing to have control. So that takes me to that assumption, which is that it's about control.
It is often about control, trying to get some kind of grasp. This is called the doubting disorder because individuals are so filled with doubt. They don't know whether to trust this false alarm that's going off in their head. They don't trust what just happened and whether they engaged in this or that. So they try. That's what a lot of the self-reassurance and checking is about, is to find some level of control and certainty. You know, they don't like they don't like gray areas. They want everything to be black and white and to fit into boxes. And, you know, if you have a fear that your parent may get into a car accident on the way home, you want to be certain that they're not going to, so you're going to do these rituals to try and prevent that.
Okay.
Maybe you're going to call and check on them. Anything that you can do to just be certain that your worst fear is not going to come true.
Okay. So then if we have some sort of correlation to control, the need to have control, would it be fair to say that that could take us back to some causal factors? Whereas we're having issues with if a person has had any sort of trauma that left them in a place of feeling very out of control, could that be connected to a causal factor?
I think it could be associated, but I would be careful to say causal.
Okay.
Yeah.
Okay. So our next myth is that there are tests that can confirm OCD.
So we don't have any, I don't think there's any kind of like blood test or medical test that's going to show that someone has OCD or is going to develop OCD. Of course, in the psychological world, we have scales and measures that,
Sure.
we do try to objectify as best we can. So with a good diagnostic assessment and particular OCD screeners that have been, built with research, we can properly diagnose.
So if a person comes to you and they're struggling with some symptoms, right? They tell you that they're struggling with, washing their hands too often, or they are struggling with, counting, repeating steps. It could be a loved one that says they're observing these behaviors. What do you do? What's the first thing that you do to begin to, help them move forward with getting some answers?
Well, I do a really thorough assessment to really get at the function of each of their compulsions and their avoidance and what is the ultimate fear, and then I tailor our treatment around those fears. So, two people can have the same category of fear, but the things that bother one person don't bother the other, and vice versa. So we do a really good assessment. We do a lot of work up front to sort of build for our treatment. So I'm going to get a good assessment of all of the things that are triggering the individual, all of their behaviors they're engaging in, including the mental compulsions and the mental avoidances. And we recreate or create scenarios, or even just put the person in the position of facing their fears, facing their discomfort, and learning to tolerate them instead of compulsing and instead of running from them. So we create this hierarchy of exposures, and that's the basis for the work that we do.
And so would that be similar or the same as exposure?
That is the exposure
therapy
and response prevention, yes.
Okay. So at this point in the show, I like to get into kind of, one, what is it that you want people to know? As my guest is the person that has been the identified expert on the subject for today. What do you want people to know? And then what are some of the things that you would, some tips that you would give?
There's a few things, because there's a lot of misconceptions about obsessive compulsive disorder, and I just want to highlight, as you said, it's much more beyond the hand washing and the perfectionism and the cleanliness. So I just want to be really clear that with those fears of harm happening to a loved one, it can be very graphic and it can be very horrific, and sometimes this will pop up in the form of a thought or an image, which is kind of like a nightmare, but you're awake. So, and a lot of people don't open up about this, and that's why I'm trying to highlight it. This could be the death of someone. There's a lot of themes around sex and sexuality that come up and nobody really talks about. And harm befalling someone or harm happening to someone. And this is the most of what I see in my office, because I think people really struggle to manage those.
Okay.
And one particular instance that comes to mind is even with parents that have a new baby around the time of the arrival of the baby, suddenly can get this onset of OCD symptoms that they never had before. Or if they had OCD, then the symptoms spike. And so it can be the same exact fears, contamination, safety, but oftentimes it will center around the baby because they realize, we want to keep our child safe and we're scanning the environment for a danger, and we suddenly realize, oh gosh, that means me too. There's this vulnerable, innocent being that I'm now responsible for.
Right.
So this is really common around the time of a baby, and luckily that's gaining more awareness as well.
And is that with just the mother or the mother and the father?
Thank you for asking that question. It is also the fathers.
Okay.
And I do treat the fathers as well.
Okay.
It's just as common, and the International OCD Foundation has taken the stance. It's likely the increase in responsibility.
Okay.
So individuals...
Makes total sense.
Yeah.
It's very scary becoming a parent.
Yes.
And I don't know what you see, but it doesn't necessarily stop when you have a second child or a third child.
Oh yes,
right?
Absolutely. It can happen only on the second child. It can keep happening with every child.
Okay.
And so the thing that I would want listeners to know is, if you are experiencing thoughts like that, anyone, is that you're not alone. And actually, everyone has intrusive, ugly thoughts. We just don't all remember them. We don't get stuck on them. Maybe we push them away and never think about it again. Someone with OCD gets stuck, and then those false alarms start going off, and they feel like, now I have to do something about this thought. They give it a lot of importance, and they feel like they have to act on it. And so just know that you're not alone, and that there's a wonderful treatment out there that can help you learn how to deal with this effectively, so you don't kind of stay in that cycle.
And so you said that there is a wonderful treatment out there, right? And so that leads me to the final myth, which is that it isn't treatable. So I found some interesting, just brief information on that many people don't seek treatment for OCD because you talked about this, they're embarrassed. And they may think that it cannot be treated. The International OCD goodness gracious, not Confederation. All right, Federation. Thank you, Foundation, says that the first line of OCD treatment is exposure and response prevention. Face your fears therapy. She just said that. So that means that she knows what she's talking about. Some people need a combination of behavioral therapy and medication, but the bottom line is that it can be treated.
Yes.
So what are some tips that you would give, whether it was leading up to treatment, maintaining, or someone who is just struggling in their everyday life in the midst of treatment?
We never promise a cure, and oftentimes parts of OCD will stick around kind of forever, but you learn in the treatment how to be your own therapist and what to do when it pops up. So we can get it down to a minimal level to where the distress is very minimal, or maybe even no longer there, but you still get the intrusions. But you know what it is, you know what to do with it. So as far as some tips, I would say look for someone who's trained to treat OCD. And a lot of therapists, say that they treat it, but they're not really trained to treat it, or maybe they don't have a good understanding of the tiny nuances. It's very nuanced, it's very idiosyncratic, so you have to be careful as a therapist catching these little things that can happen, especially the mental compulsions. And so just looking for someone that's trained in exposure and response prevention, has treated a lot of individuals with OCD, and then just really committing to leaning into the exposure and facing your fears instead of fighting them the way you have been, because it's probably not working out.
And what would you say to loved ones and how to best support somebody that is struggling with OCD?
Yeah, if there's any way to get them help with an OCD specialist, that is the first thing. But there are a lot of resources on the International OCD Foundation website. There's a book called Loving Someone with OCD that has a lot of great information. And the best thing you can do is get them into therapy and gradually start reducing your accommodation of their OCD, because that helps them stay stuck with the OCD. So we see a lot of family members engaging in rituals and avoidance and helping them do those things and doing it for them, and that actually keeps the cycle going and reinforces that all of this has to be done to keep the person more comfortable.
So you're saying that you have seen family members actually participate in the obsessive compulsive manifestations?
Yes, I see it all the time. And so I usually bring in the family for 1 or 2 sessions for education and teach them how to gradually pull away from accommodating. We don't sort of just stop it all at once, but they begin to learn how to not accommodate and provide reassurance, and we back that away to where they're not doing it anymore.
So are there any other tips that you can think of for supporting someone? I think about places like the workplace. If you're an employer that's listening right now, what is something that you would advise in terms of how they can better support their employee?
Of course, I mean, being understanding that their employee may have a difficult day and need some time out, some break. If there's a delicate way, you might be able to suggest that they seek treatment. Of course, that would be the best thing. I probably wouldn't put an employer or anyone in that kind of position to back away from accommodating unless, the individual wanted to involve them in their treatment. So.
Okay. So if you're in a workplace and you have an employee that you that the obsessions or have the compulsive behaviors have become maybe more distracting, not maybe to the point of problematic, but distracting. What would you suggest as an appropriate and helpful response?
I think the best thing they can do is try to get them into treatment. I mean, that may be kind of an odd place to come from as an employer, but that's really what that person needs if you want something to change. It's not going to change until they start facing their fears and having the support of a therapist, hopefully.
Right.
So.
Okay. And so we are coming down to the end of today's show, and as always, I always want to give you all the opportunity to reach out to our guest, reach out to myself. If you know someone who is struggling with OCD, truly struggling, and you have a legitimate concern, or even if you don't know if it's a legitimate concern, if you know someone who maybe is flippant about their symptoms, but you've been around them long enough to notice that, they joke about this because, as we talked about at the top of the show, it seems to be socially acceptable to almost make light of it now. But you're noticing that there are really some significant and serious behaviors that are questionable, that you think may be harmful. Any of those things like that, it's really important that you do reach out for help. And so I always like to leave my guests, give them the opportunity to leave their contact information and to leave my contact information in case you want to reach out to myself or my guest and for some reason you can't remember. So if you want to give your contact information or any information you want to give that would help them, someone who may be really struggling, to reach out directly to you.
Sure. So my email is office@allayocd.com. So OFFICE@ALLAYOCD.com. Phone number is 816-663-9OCD. And there's also my website at allayocd.com.
And can you spell Allay again?
Yes, ALLAYOCD.com.
Okay. And then my contact information is 913-820-2173. Again, that's 913, I forgot my phone number, 820-2173. Also, you can reach me at abundantlivinglegacy@gmail.com. Again, that's abundant with a T on the end, livinglegacy@gmail.com. You also can reach out to me on my website, which is abundantlivinglegacy.org. Also, you can inbox me on Facebook, as you all well know. And if you have any questions, concerns, I want to encourage you all to share the live video. If you are watching on Facebook, please share it. You just never know who in your general circle may be struggling. And today, if anything, we've discovered that this particular disorder does tend to come with a lot of shame and embarrassment. And so I want to strongly encourage you all in the listening audience to share the link. If you want the link for today's show, I can get that to you. And then also, if you are watching live on Facebook, please share this, because again, you never know who is struggling with this. That is going to be our show today for Talk About It Tuesdays. You have been listening on Urban Talk Radio 100.5 FM. Please join us back next week. We are going to be broadcasting live on Facebook at 9:30, and then you can catch the show live on our radio dial at 11 a.m. Thank you so much. Be blessed. And remember that we're here to connect you and your loved ones to the resources you might need to live a more abundant life.